palpation of the knee. There's not a whole lot here, so it should go pretty fast. This is a little bit high, and for those of you who are not as tall as I am, this is going to be really high for you. So honestly, in the clinic, what I do, which won't work for those of you who aren't my height either, I will tend to palpate by just putting my knee under their leg, because then the knee is at a little bit better angle, but for not all of you will be able to do that comfortably. Okay? If we pretend to go in order, I should be palpating on the other leg. Okay. So obviously, we have a kneecap. So patella, so inferior pole is where the infrapatellar tendon goes. The patella is a sesamoid bone embedded within the quadriceps. So this really is a tendon and not a ligament. Sometimes you'll hear people call it a patellar ligament, but because it's a sesamoid, it doesn't qualify as a ligament. You need to be able to palpate all the way around the patella. When you don't have the knee very flexed, you actually will be able to move the patella as well, but you'll learn how to do that next summer. Okay, so then in this position, I can also palpate the joint line, and that's going to be pretty subtle, particularly on the medial side, because we're going to have the medial collateral ligament running across there. But you need to be able to palpate there because this is really our only access to the menisci. And if you have joint line pain, a lot of times you will then suspect or hypothesize that the meniscus is involved. I had to have a meniscectomy a couple years ago, and my meniscus had flipped over so that you could actually see it. It actually stuck out, which was crazy. What?
How'd you do that?
Soccer drill when I was coaching. It was pathetic. But it was so sensitive that if a sheet touched it, it would just send me through the roof. So I finally had to have surgery. Have you guys not heard this sad story? My doctor, she shows my husband the pictures afterwards, and she goes, "Oh, and the cartilage was a little messed up. It was a little sloppy, so I just cleaned it all up." And I'm like, "No, leave my cruddy cartilage in there." So it took me 15 months to be able to get back to running again. Because I now not only don't have a meniscus, but now I also don't have the articular cartilage that she cleaned up.
Should she have known that?
What?
Should she have known that you might need them?
Orthopods want it to look pretty. They really care about pretty, and then I'm like, man, I'd take as ugly cartilage as I can just to have something in there, because it's not like I've got a light load. Like I really want that.
It's not like it's growing back or anything.
No, right. I'm done now, so it's kind of a bummer. Okay, so medial joint line. Laterally, there's going to be a lateral joint line. The lateral collateral ligament is going to be the thickness of a straw, but obviously not collapsible. So it's going to feel like a ligament. So this is going to be a great ligament to find. One way to find it is the way Tanner is sitting. If you cross your legs in what's called the figure 4, and if you go to your lateral joint line, your LCL will just pop right out at you. Okay, so the figure 4 is a great way to get to it if you can't find it when you're in this position. All right, so medial joint line, lateral joint line. The medial meniscus is really more of, medial collateral ligament is more like a thickening of the fascia again, so there's not a whole lot of ligament that you're going to feel on the medial side of the knee. What will happen is you won't be able to feel the joint line under it very well, and you'll know you're on your MCL. Okay. The other thing for MCL versus the meniscus is the MCL, it's going to hurt not just on the joint line, but along the length of it. And also for a meniscus, it's going to be very specific to the joint line. Okay, so just for the differential. For the lateral joint line, we talked about you're just going to find the joint line again, and the LCL or lateral collateral ligament is really going to be that thick thing that you're going to feel crossing it. And again, the figure 4 is the way to find that if you can't find it in this position. If we follow the femur up, we're going to hit the medial and lateral epicondyles just like we did for the humerus. So the femur and the humerus are very similar in structure, obviously. So you're going to find those epicondyles. On the medial side, as you come up on the medial condyle, you're going to hit the adductor tubercle, which is the distal attachment to many of our adductors. If you're not sure you're on it, Trevor, go ahead and just squeeze your leg towards me here, outside this direction. There you go. And you should feel the adductors fire, just proximal to that. And you'll know you're on the adductor tubercle. The lateral epicondyle is going to be a landmark for a lot of goniometric measurements. So you need to be able to find that. So again, that's just going to be that widest part of the base of the femur for the medial and lateral epicondyle. There are going to be medial and lateral supracondylar ridges that are, if you just follow the epicondyles up, you'll be on those ridges. Okay, and that's going to happen medially and laterally. If we go distal, we're going to have our tibial tuberosity, which is where that infrapatellar tendon attaches. So it's the knob on the front of your tibia. Okay, bone forms based on imposed demands, and so some people will have pretty prominent tibial tuberosities. Did you talk about in anatomy what the disease is? Osgood-Schlatter's? Good. Which affects more men than women. So look for a prominent tibial tuberosity. So on the lateral side of the knee, I'm just gonna switch over here for you. Can I roll you this way? Are you okay? We're gonna have two structures that are easily confused. One is the fibular head, and one is Gerdy's tubercle. Okay? They don't look like they should be confusable, but they are. So what attaches to Gerdy's tubercle? The IT band. Okay? And then obviously the fibular head belongs to the fibula. The reason the fibular head is important is the common peroneal nerve is going to wrap around, just around distal to the head. So you're going to find the fibular head and then come posterior and see if you can find that common peroneal nerve. Okay? So those are two lateral structures. Medially, well, is that enough? I feel like I'm keeping going. Okay, we'll stop there. Popliteal artery is really tricky to feel. It's going to be in the groove on the posterior knee. What you need to do is these are the heads of the gastroc, so you need to be anterior to those, but not up into the hamstring muscle bellies. Okay, so the back of the knee is called the popliteal fossa, and we're going to have our popliteal artery right in that space. Okay. I typically palpate that with a patient in supine, and I'll show you that in just a minute. As soon as you put them prone, you can have the hamstrings a little bit too long. You want to have the knee a little bit bent and then go into that popliteal fossa. We talked about all of these. This is just showing where the common peroneal nerve comes around that head of the fibula. Okay. So then we're going to get into palpating the bursa. So we have so here's the patella. So we have the suprapatellar, so it's going to be superior. We have the infrapatellar, and then we have the prepatellar, which is going to sit right on top of it. So if someone has a prepatellar bursitis, it's just like our nursemaid's knee or elbow. It's going to be just huge, and it's going to be just sitting right on top of the kneecap. Now, there's a fourth one here, which is our pes anserine bursa. It's where our semimembranosus, semitendinosus, and gracilis all come together, so the duck foot, right? Come from behind and come and attach to the anterior medial aspect of the tibia. A few months ago, my bursa was swollen, and I was super excited because I was going to let you guys all feel my swollen pes anserine bursa, but it's gone down now. So I don't have that for you for show and tell. But so again, like all other bursa, you need to know where this is, but unless it's swollen, you aren't going to feel anything there. Okay? Now the last thing I want you to take a look at for pictures is the plica. So this is the medial aspect of the knee. This is the posterior aspect of the knee. Have you all talked about the plica in anatomy?
Yeah.
Sounds like it's the appendix of the knee. It doesn't really serve any purpose other than to be irritated in people. So it's going to be superior medial to the patella, and it's going to feel like a ruffled potato chip. Okay, so you're going to feel those grooves, and you're going to go cross fiber on that. If it's swollen, it can cause a lot of problems with patellar tracking, okay? And so you're going to try to find the plica on that superior medial aspect of the patella. Okay? So we'll go in the back. I think that was it for my pictures. Yeah, that was it for palpation. So I will demonstrate those in back.
Yeah, they shaved it off.
Thank you. So I need knee. Thank you, Trevor.
Yeah.
Oops, sorry. So for the pulse, I'm going to support the leg with one hand and then palpate with the other. What this does is it gives the knee a little bit of flexion so that it's looser. Now again, as I've repeatedly said, I don't have very much upper extremity strength, and so again, I'm keeping his leg close to me. Okay, I don't have him out here because I wouldn't be able to sustain that very well. So I'm keeping that load, that massive load, very close to my body. Okay.
I wish.
Now I'm going in superior to the gastroc muscle bellies, but not so far to be up into the hamstring muscle bellies. And if anything, it's going to be more medial than lateral. And you can almost let the leg then hang on your palpating finger. And Trevor's not going to make my life easy for me. So I'm not finding it on Trevor right now. This is one of the pulses I want you to try to find. Okay, if I find it on somebody. The other thing is the harder you push, like I started to get excited because I thought I could feel a pulse, but it's just mine because I was pushing so hard. So remember, if you push too hard, you're gonna feel your own pulse and not your person's.
Did you say it was more on the medial or the lateral side
It's
of that pulse?
more medial.
More medial.
Tends to be, but it's just running posterior knee, so if you can't find it, fish around. But you just want to make sure you're not going, you want to be in that sweet spot of the popliteal fossa, so you're distal to the, or inferior to the hamstrings and superior to the gastrocs. Okay? So then, see, look at so prepatellar is going to be right there. Suprapatellar is going to be there. If you think about the capsule for the knee, if you put the patella in the palm of your hand and reach your hand forward, the capsule of the knee goes as high as your hand, okay? So we think of the capsule only being right around the joint, but the knee capsule in particular will actually come up really pretty high. So next semester when we do some anthropometric measurements, you need to go pretty high above the knee to capture all of the swelling. So infrapatellar is going to be down on the infrapatellar tendon. It wasn't on the slides, but we have fat pads that help the patellar tendon slide. You're going to get to those by going on either side of the infrapatellar tendon. And then for the plica, you're going to come, thank you for that. So who's his partner? Okay, so he has a really nice plica and you can just run right over the ridges. So if you can't find it, let me know, okay? And Trevor, it's right there, okay? So I think that was all we covered. All those different bursa and the pulse and then the plica. And then we're done with palpation already.